Hello and welcome. I think there's going to be a little bit of don't worry, a little bit of shuffling of chairs, and then we'll be ready to go. So, welcome to everyone. This is the meeting of the Leicestershire and Rutland Joint Health Scrutiny Committee. Obviously, this being the 17th of March 2025. Welcome to everyone. This is being broadcast live to the public via the YouTube channel on the County Council's website. It will be available, obviously, through that website afterwards if anyone wishes to rewatch the edited highlights. On the microphones, anyone who's been in this room before will know that we have a slightly sort of quirky system here at County Hall. There are 4 cameras to capture your good side whenever you wish to speak, but that will only happen if you actually press the button to make sure the red light comes on just at the point when you're about to speak. But please do press the button to get the red light to go out as soon as you're finished, because otherwise the next person after you won't be captured on the video system, and instead you'll be filmed looking into the air or reading your notes or whatever. So with that done, I'm going to also add that there is not an expected fire alarm testing this afternoon. So if you do hear the fire alarm, it is for real. There are fire exits, obviously, in each corner of the room. You can follow the respective signage to get out, and the meeting point from memory is somewhere in the car park. Is that right, Ewan?
Out towards the cricket field.
Cricket fields, yes. So in that direction. So anyway, just follow everyone else, and hopefully you'll be absolutely fine. We do have apologies from Councillor Joel. Do we have any other apologies, Ewan, that we're aware of? No, I think we're all here. So that's good. So look, we're going to start the meeting proper in that case, if that's okay with everyone. We have item 1 to start off with, which is the minutes of the previous meeting that was held on the 27th of November, which I think, Karen, you actually chaired for me. So thank you very, very much for that. I understand it was an extraordinarily efficient and swift meeting compared to anything that I've chaired. So well done. Thank you very much. So for all of those who are at the meeting, are you happy that the minutes are as they should be? Excellent. Okay, thank you very much. By the way, this is the last ever council meeting that I'm chairing. So if it goes very swiftly and I have a smile on my face, then you understand why. Dean Mob happy, absolutely. So hopefully it'll be a good one. So look, item 2, question time. So we have had 3 questions from members of the public, 2 of whom I think are actually in the room. So we will come to their questions in a couple of seconds. There is an opportunity. Those questions have been answered by our health colleagues. Those answers have been fed back to the questioners, and they will now have an opportunity to ask supplementary questions. The supplementary questions, if they can be to the point on the question that was originally asked rather than actually a new area, and likewise in relation to the answer that's been provided rather than, again, another point. So of the 2 questioners, I'm just going to check with Ewan. Who's first in that case?
I think Councillor Bob Waterton's first.
Okay, in that case, Councillor, if you would like to come up, if you want to use one of the corner microphones, and if you want to ask your supplementary, make sure the red light is on for the speaker, and that's fine. Now we hopefully colleagues are actually in the room, NHS colleagues are in the room. So anyone who thinks they're about to answer a supplementary question, do you want to actually come up to the desk as well? And then there's an opportunity to actually answer that. That would be great. Okay, I will pass over to you now. Okay, thank you.
Okay, so am I being heard?
Yes.
Yes, thank you. Right, thank you for the answers to the 3 questions then. Presumably it's this gentleman here, is it, that's answered those questions. I have a supplementary question regarding answer number 2 on the sheet, which I suppose everybody's got. So thanks for that answer. I noticed that in agenda item 8 at this meeting, Chair, the paper that's tabled by the UHL, there's a reference in paragraph 7 to the consolidation of sites and the need to act sooner. So could you please say what is being considered regarding the consolidation of sites and whether such consolidation is being considered before 2032, which is the alleged point at which money might arrive. So that's the supplementary, Chair. Thank you.
Okay, thank you very much. If you could just press your red button, and then likewise, Bernard.
So, Chair, I just wanted to know whether, did you want me to answer these questions now or consider them as part of my overall update? Because I'm aware that we might be dancing backwards and forwards in terms of...
If you could do them now, that would be great. And then if we need to refer back to them during the general discussion, then obviously we can reference that point. But if you could do now.
Okay, so the original plans that we submitted way back in 2019 had a series of drivers underpinning them, of which there was a reduction in the delivery of care at the Leicester General site. And you believe that the ICB actually consulted the public on that through COVID. Clearly, as time has gone on, things have changed. And you'll note that we have, as the organisation has built East Midlands. Yep, you'll note the organisation UHL has used public TIF money to build East Midlands Player Care Centre. So in the ongoing plans for the organisation, the increasing use of Leicester General site is for a high volume, low complexity care.
Okay, thank you very much. If you could press the button again, likewise. Do you have an additional supplementary question in relation to any other parts, or are you there? Yeah, if you ask any other supplementaries in one go, that would be great.
Wrong. I had a supplementary, Chair, with regard to question and answer 3 under Standing Order 35. So this is really for clarification, Chair, if that's possible. What's being said is that if any private capital were to be required for the UHL scheme, it would be the new hospitals programme within the Department of Health and Social Care, which would be responsible for sourcing it and allocating it.
So that...
Sorry, if you can press your button to take the microphone.
So there is no indication at present time from the government or the Department of Health in terms of the involvement of private capital. So we await announcements from the Secretary of State for Health or the Treasury.
Okay, thank you very much. Is that's the rest of the supplementary? That's great. Thank you very much for that. Obviously, if you stay around for the rest of the meeting, because this is obviously one of the items that we're going to be discussing, and then there'll be an opportunity, hopefully, for other members to ask questions in relation to that.
Thanks, Ed.
It will come through the minutes of this meeting, and then obviously it's recorded on the YouTube channel as well. So if you want to refer back to it, then you can do. Okay, we've got.
I go now.
The next question, if you'd like to come up and ask your supplementary. Microphone's been left on for you, so you won't have to press any buttons.
Thank you, Chair. The first supplementary is supplementary related to question 1. This is regarding the piece of work to involve the expected start date for construction. So the question is, when will it be completed and will it be placed in the public domain at that point? This is the clinical impact review that's being done.
Sorry, Chair, so this is Mr. Jennings?
Yes.
Right, okay. And the question was around possible dangers. Yeah, so the Trust is undergoing a piece of work starting this month in terms of engaging with the clinical leadership teams within the clinical management groups of the organisation. We expect that review to be considered worked through within 3 months, and obviously it will then be available via Trust Board minutes.
Very much.
Thank you. So you said three months, and then it would be available through the Trust Board minutes. That's my understanding?
Yes, so that there's through the internal management escalation structure within the trust, that we've through the relevant committees, of which are obviously some of those are publicly available.
Thank you. I also have a supplementary for question 3. And the question is, would an earlier refurbishment of existing estate rather than later new builds be expected in our future hospital scheme be better for patients? In other words, involving refurbishment before a date for the planned new hospitals, or is waiting longer for new builds the best way to go, or the better way to go?
There is no easy answer to that question, and it will relate to some things I will talk about later in terms of the availability of capital within the new hospitals programme for enabling works, and the review that's going alongside the clinical review in the UHL from an estates perspective. Obviously, the ICB has a large capital allocation, some of which is spent by UHL, and how that money is spent in the intervening period will be subject to, as is always, discussion and review on the basis of those reviews that I'm talking about.
Thank you. And one final supplementary on question 4. You said there is a backlog of estate improvement and maintenance costs of 125.7 million, 37 million worth of which would be dealt with through our future hospitals. What is the estimated cost of additional problems with the estate which could be expected between now and 2032?
I'm afraid I'm not in a position to answer that question, just from a lack of technical knowledge.
Would it be possible for an answer to be provided by another colleague in that case, and we can do a written response on that?
Yes, absolutely, from a written response, yes.
Okay, that's fine. So we can follow up. Ewan will take note, and we can follow up and ask for a written response to you on that one.
Thank you, Chair.
Thank you very much for that as well. Now, Ben, you might want to stay in the hot seat, as it were, because we've got some more questions. So look, thank you very much to our 2 public questions. We have had a third as well. Unfortunately, they're not able to actually attend to ask the supplementary question. So, but they will be able to actually resubmit that question in future meetings if there are further points they wish to ask. So there is a process for them to actually follow through, even though they weren't able to actually be at this meeting. We're now on to item 3, which questions asked by members. We've got Councillor Ross, Ramsey, you've got a question that you would like to, that you've submitted, and I think you want to actually now ask a supplementary in relation to that.
Thank you, Chair. Yes. Thank you for the very comprehensive, the very comprehensive paper that was provided, and the various attachments. Just from that information, we see that University Hospital Leicester in October had 5.47% absence, with an average of approximately 5% in the year. I used to work in the steel industry until 2011, and in 2011, the blue-collar labour force had an absence of, we had a total workforce in the UK, just over 22,000 people, had an absence level just below 3%, and we had staff absence of below 0.6%. And I note from a further supplementary paper that professional staff, in terms of cold, coughs and flu, represent 51% of the total absences from this cause across England. So my question is, are we seeing a proper demonstration of leadership by our professional staff in encouraging the take-up of vaccinations in the workforce more generally? Thank you.
Thank you very much, Ramsey. Now, the only problem with that one is Ben is looking at me slightly quizzically, because he's here to talk about future hospitals. What we haven't got is, unfortunately, one of his colleagues here to actually give you your answer, but your supplementary has now been lodged. Ewan will be able to get a written response to that, as you're aware. So Ben, don't worry, don't panic. You're not going to start talking about vaccinations. But thank you very much, Ramsey, for that, and we will make sure that the supplementary gets a written response through the relevant person very soon.
Thank you very much, Chair.
Thank you very much. I could see glances from Ben of sheer panic at the thought of having to suddenly find a new specialism, but hopefully you can calm down now. It's fine. You're back onto a much more less contentious issue on hospital building programs. Okay, look, we're now on to item 4, which is urgent items. Haven't had any response or any put to me. Declaration of interest. Are there any members with declaration of interest? Bessie, your usual one. Okay, you and I know well knows the usual one, which is relating to family members. Ross, which is that you are in the medical profession yourself. Absolutely. Brenda's family members. Any others? That's what I think they are very, very good declarations in that case. Thank you very much. Any others? Family members, excellent. I was going to say, having noted in one of the papers, I think the 30,000 employees of NHS in Leicestershire, it's very difficult not to have a family member. I do not have a family member, but I do know plenty of doctors and health officials. Any others? No. Okay. Good. Thank you very much. Okay, I think we're done with declarations, so that's great. So we're now on to declarations of party whips. I'm assuming there are no declarations of party whip. No, absolutely not. Good. Thank you very much. So presentations of petitions. We haven't had any petitions presented. So we're now on to paper 8, which is the UHL Our Future Hospitals paper. So Ben, everyone is already aware with, who's the Associate Medical Director at UHL. You're going to give us an update. You've provided a very brief paper, obviously, on the position as we are at the moment. We take all papers as read on this committee, so please assume that everyone's actually read this. However, if you, in this case, you may actually want to probably give more than 30 seconds introduction, but a very quick oversight. Anything that you wish to draw to attention that's already in the paper, or alternatively, anything that's come up more recently, then by all means, there's an opportunity to say so. And then I'll open it up for any questions from any of the committee members. Over to you, Ben.
Thank you, Chair. I'm just going to put, as you said, I'm going to take this as read, but I'll just pull out some salient points I think that might prompt the discussion. So we're obviously all aware of the Secretary of State's announcement on the 20th of January. I think everybody at UHL shares everyone's disappointment that we became a Wave 2 scheme, but I would like to put that in context that actually there are other health trusts in very close proximity to us who's received very significantly worse news than us. And what this does do is confirm the funding allocation of between £1 and £1.5 billion. It started our programme in 2028, so it's a delay of 3 years, and the Treasury, as part of this process, has confirmed a 15-year capital funding pipeline. So there is more assurance in there than we had before. What are the bits to sort of bring out, obviously, and as alluded to in some of the questions, that whilst this, I think it's important to remember that no new risks, clinical risks, came out as a result of that discussion from the Secretary of State for Health in January. So those risks were there. Our Future Hospitals programme is named as mitigation for a lot of those clinical risks. So whilst there is a 3-year delay, it's important and that we are conducting a clinical review now to see are there any new risks that will present themselves as a result of that delay, and does the fact they're not going to be mitigated present a material problem. And in line with that, the same review is being conducted from an estate's perspective around backlog maintenance. For the avoidance of doubt, the specific areas of clinical risk are pointed out in item 8 in the report. And I don't think I've got much more to add, other than to say that it's clear that now there's a fixed funding envelope for the programme. They will obviously have to meet their spending needs, spending requirements each year. So should there be any delay in delivery, there will be capital available. And there is some indication that that may go to enabling works of those schemes early on in the programme. So I think from our perspective, we remain optimistic. We remain totally focused and committed to delivering what we've said we will do, and we await further announcements from the new hospitals programme.
Thank you very much, Ben. Now, I've seen 2 hands go up so far. Karen, it's the first one, and then Trevor, and then Janet following that, and then Ross.
Hi, Ben. I just wanted to ask what the time frame was for the review. I know it starts in March, but what's the timeline for it?
So all of our meetings will be conducted. The first round of meetings will be conducted by the end of mid to end of April, and we're hoping to have the whole process completed by the 1st of June, which is in line with the group clinical strategy coming out.
Okay, and then Bessie's on the queue as well. So now Trevor.
Thank you, Chairman. May I ask, in view of the delay and contract deployments, are there any additional costs which will accrue because of lack of contract continuity or deployment or clarity that this delay has brought about, which you'll have to absorb?
So in UHL, in line with every other scheme that's not in wave 1, has been put on a hard stop. So there is the funding from NHP has ceased as a consequence of that, and people are drawing up plans for their teams around the country.
Thank you, Chair.
Okay, thank you very much. I think I saw what's next.
Yeah, so obviously the money we're coming from the Treasury, and you will work with the Department of Health and Social Care on this. I'm just curious, last week the Prime Minister announced the abolition of NHS England, and will that have any impact on the delay?
I think it's fair to say that the UHL found out about this at the same time as the public did, and you did, and at this time we're not in a position to comment any further than you would be. So I think we need time for the dust to settle and to work out the implications of that.
I suspect that question will probably come up a little bit later on as well, actually. So that's a very good question. Janet, I think you were next in line, and then it's Bessie after that.
Thank you, Chair. Yeah, I'm referring to the risks you've highlighted in section 8. I feel this is a bit like Groundhog Day, because about 7 years ago, we were arguing about the need to have level 3 beds continuing in ICU at Leicester General Hospital. We were arguing too about not consolidating maternity care onto one site, and particularly closing Melton Mowbray. And we were arguing about bed closures. And now you've highlighted them as a risk. And I'm just wondering what mitigations you've got in place for those risks, and what you can do about it, really.
So I think it's important to say that the risks that we have listed from a clinical perspective may be different from the perceived risks that you've alluded to. And certainly around maternity, they are now subject to national advice and requirements from the CQC. So some of the risks that we've got around maternity and neonates is actually it isn't possible to provide, or it's certainly very difficult to provide a consistent level of care across 2 separate sites. So from a clinical perspective, consolidating those means that we can provide safer care. So those risks continue, and as I've said, part of this reason that now there is further delay, we'll need to look at what the mitigations are. Clearly, we've all got a responsibility to spend public capital in the most prudent and sensible way, and up until now, it's been deemed that using the new hospitals programme money and waiting is a better way of a more efficient and, from a capital perspective, way of doing things. Whether that changes as a result of the 3-year delay, that will come back and lay out.
Yeah, what about patient safety, which is the most important thing, and the fact that you're doing probably quite complex urological surgery at Leicester General Hospital without any level 3 beds there?
So that complex urological surgery is currently being conducted at the Glenfield, specifically for the point that you make. So I think it is important to say that whilst we talk about clinical risk and the new hospitals programme being the only mitigation, that is not to say that clinicians or operational leadership are sitting there delivering unsafe care. It means that there are mitigations in place, but they're not clearly as good as building a new urological hospital at the Glenfield. So I can assure the councillor that everything is being...
Not a councillor.
Oh, apologies.
Yeah, we'll be very upset if you call him a councillor.
Apologies. I can assure Janet that on a day-to-day basis, everything is being done to deliver the safest possible care possible.
Very last supplementary.
Somebody goes in for surgery at Leicester General Hospital and something catastrophic happens such that they need a level 3 intensive care bed. What happens then?
There is an HDU facility there that will care for the immediate care of the patient prior to them being stabilised and transferred, which is not any different from lots of other hospitals all over the country.
Okay, thank you very much. We've got Betty, then I think we've got Sufa, then we've got, who else? We've got anyone else? Okay.
Paragraph 5, it talks about Leicester are positioned as an initial recipient of funding. Does that include Leicestershire as well, or are we just talking about Leicester Hospital?
Apologies. Could we just, lost a bit, which bit of the report we're talking about?
So you could just repeat.
It's page 11.
So well, on your report,
5.
it's page 1, paragraph 5 in that case.
Okay, apologies.
Okay, right. Oh yeah, I've got one on the bottom of it. I can see that now. Yes, it's more or less to find out if it's wider than Leicester.
So obviously that 15-year funding pipeline is for the new hospitals programme and the schemes in it. Mm-hmm. So because we are in wave 2, right, and as actually if you're ruthless and go through the timings of all the trusts in wave 2, you'll find out that our start date is before everybody else's.
And but just for supplementary, I think this in relation to UHL on the basis that just covers the 3 hospitals in Leicester. Because it's not for instance, it's not Loughborough Hospital.
No,
that's a completely different category.
That funding pipeline is only the new hospitals programme.
That's fine. I just needed clarifying, I thought. Thank you very much.
That's okay. That's a helpful clarification for anyone listening.
Thank you. My question is really, given the level of risk and particularly level 3 beds at the general, the neonates, maternity services, there was lots of reviews done over the last 20-25 years saying that maternity services need to be on one site, one unit. And the promises from government for the last 25 years, this is not going on from this government, but this has been going on since 2000, the whole pathway fiasco of 2005, 2007, and so on. And we never, it's like trying to catch fog. We never seem to get to the hospitals. And I know you said that, some of our neighbours haven't got hospitals, haven't got some of the funding, but Peterborough is a brand new state-of-the-art hospital. Derby is, Coventry is, Birmingham, they've just built a new one at Sandwell, and lots of other places. We're losing lots of good quality consultants and other staff to lots of other hospitals around surrounding areas which are commutable, and at the same time delivering really poor patient experience because the buildings aren't really fit for purpose. So are you more hopeful that this time you'll be able to catch it? Because you're talking about a change of government, a driver for defence spending, and where will the money end up coming from?
So the specific question is, am I hopeful? Is that fine? I am known for having a glass half empty approach to life, but it's an impossible question to answer. I think the point that I was seeking to make is that we have ridden this wave of disappointment and delay for many, many years, as have other hospitals. But actually, as a hospital and as a team, we have remained positive, resolute, and continued to engage with NHP in as positive a way as possible. And as a result of which, I think our place in the programme is pretty good. Now, before you shoot me, if you look at who's in wave one, it's all of the RAC hospitals, which are frankly falling down, and a couple of others. There's some accelerators where they're doing proof of concept, and the only other really large hospital that's in there is Manchester, who have conducted a lot of enabling schemes and have always been consistently way ahead of us in terms of where they're at in terms of their business case process. So if you take that pragmatic view, then the next set of hospitals is wave two. And as I've alluded to, if you ruthlessly go through the start dates of all of those trusts, you'll find that 2031 as our construction start time is before everybody else in that wave. So I do remain positive around that, and the fact that actually the Treasury have committed to that funding pipeline. So does that mean that world events might change? We might be the 52nd state by the next time I come in and talk to you. Possibly, but I think in the absence of any of those things, that we're in as best a position that we can be in. Now, that I agree with you that that's not. If you take a real cold Leicestershire view of things, that's not acceptable. But it is what it is, and we are where we are. And I think we're in the most favourable position that we could have been possibly. And if you look at Leeds, who were ahead of us in terms of where they're in the business case process, they have been told to stand down completely and not come back until they've resubmitted their entire planning application around a hospital 2.0 compliant building. So actually they are significantly behind where we are. So in that context, I think we have to remain positive. And it also, I think it's worth pointing out, there are a significant amount of capital funding that comes out through the ICB on a yearly basis, and hopefully things like the group clinical strategy and the group strategy and all the things that are happening around ICBs might mean that we're able to continue to deliver construction projects within UHL in the meantime. And it's not forgetting, in the last 10 years, we've spent over £180 million of new buildings, so that our team has not been really quite busy doing other things as it is. So I think we need to continue to do that in a positive way whilst we continue to wait for our slot.
Okay, thank you very much, Ben. Look, very brief supplementary.
Yeah, sorry. I'm glad about the positivity, because I remain positive as well. And I keep telling consultants who ring me and said it's not going to happen in our lifetime, telling them the same thing. But when the ICB is in debt by £80 million, that the chances of funding of coming in to Leicester hospitals is really bleak. And people like me are just busy lobbying our MPs to make sure that we get our share. What would you suggest we do?
Keep doing that. I think there are huge challenges to it, but there are a lot of positives that exist in Leicestershire in terms of our EPR development. We're the international development partner of Nerve Centre, which is the fastest growing electronic patient record in the country. Where their development site, the changes that we're able to bring in terms of delivery of clinical care and better use of funds is huge. So I think we need to continue to be positive, to keep transforming and delivering care where we can, and this shouldn't be seen as the saviour for everything, because actually it only touches 25% of our estate and services. So actually there's a whole other area of activity far greater that needs to continue to transform and evolve in the way that it delivers care. So no one should take their foot off the gas.
Okay. Thank you very much, Ben. Look, thank you very much also for the comments. Ben, I know you and your colleagues are well aware of the frustrations that you have internally that are shared by councillors and members of this committee and the wider community in Leicester and Leicestershire and Rutland. We want to get the build programme going. We all understand why it's important. We understand also that we are competing against lots of other schemes up and down the country and governments who face the cold reality of taxation and spending on a day in, day out basis. It's a difficult position to navigate. We could have been in wave one, but that would have meant that we would have had a hospital dominated by RAC and ruined. And as you said, the consequences of that are not great either. So wave two, hopefully your glass half full is the right assessment, in which case the build programme will progress. But I'm aware, as I'm sure every other member of this committee is as well, unfortunately we are living in slightly unstable times. And as Karen and I were talking earlier on, it is very difficult making promises to people when you know full well that the environment is not as stable as you may wish. But please keep on pushing ahead. We have contacted the Secretary of State through this committee after the last meeting to push the case for the programme. We will carry on doing so in whatever form this committee is constituted after May the 1st, because that programme is important to our residents and it's important to the county that we actually support you and your colleagues to get it underway. So thank you very much. Okay, look, thank you, Ben. Anything you need from us in the future, likewise, but I'm sure this committee will be asking you back for updates and progress over the next couple of years without a shadow of a doubt.
Thank you very much.
Thank you. Right, we're now on to the next item, which is item 9, which is the LLR Health and Care People Plan. So Alice, you're joining us. Alice is the Chief People Officer at the ICB and is going to be helping us with this report. As I mentioned to Ben, we take all reports as read, so everyone's had a chance to look through your report and also the slides that went with it. However, if there are any points that you want to actually focus on or direct us to that you think are key points in the report that are important to get to, by all means, use the next sort of minute to do so. But otherwise, we'll then launch into questions, any points that members wish to make.
Thank you, Chair. And just a 60 seconds context. Some colleagues around the table will have seen a very similar report that went to our public board for the ICB in February around giving assurance around the progress we're making around supporting our people into health and social care. So rather than just health. What I will say is this does not include everything that happens in every part of our health and social care system. What we try to do is use our resources wisely. That says, where does it make sense that we do things once and well together, doesn't duplicate effort, and actually might solve challenges that we've had at an organisational level that we can't solve on our own, so across health and social care. Now, I've just tried to pull out some of the key areas that we've been focusing on, what's our strategic intent, what are the things that we're doing together. And I've pulled out some of the key metrics that we're seeing some improvements in, and listening to Councillor Hack's concerns around, are we losing good people? Are we losing our staff from health? Actually, a lot of our data from health and care is saying we're improving. We're improving staff satisfaction, we're improving retention, and we're reducing our vacancy rate. So really happy to take any questions beyond that.
Thank you very much. I'm going to come to Betty in a bit. Ross asked a question on the previous round about obviously changes with NHS England. Can I ask him to actually re-ask this one, because I think it's a topical question, and I know you probably would be expected to be asked it.
Thank you, Chair. So it's just a general question. I suspect it's a bit harsh to ask you at this moment in time as well, but last week the Prime Minister announced that NHS England was getting abolished. Now, obviously, that's the arm length national body of the NHS, and that's getting absorbed into the Department of Health and Social Care. So what impact do you think that will have on your plans going ahead?
I think it's a really pertinent question, and you are right. We don't know the answer yet. So on Wednesday evening, chief executives were briefed and were not allowed to brief colleagues, and Thursday it broke into the news, and so we're still waiting to say what does that mean? What does closing one organisation, absorbing it into another mean? And we are talking around target operating models. So what will retain at local level, what's part of neighbourhood plans, and I think over the coming weeks we'll know more and more.
Can I ask whether ICB have been given targets as well for reducing overheads?
Yes, so we have been given a target of reducing by 50%, and that was covered by the Health Service Journal last week. So that's NHS England and ICB's will change, but we don't know the detail behind that yet.
And that's by Q3, which is the end of this year.
Correct, yes.
That's quite a significant change. Okay, thank you. Right, I'm going to come to Betty in that case.
My question's really on page 26. It's about the turnover rate, and which is 23.7%. And I was just wondering if you could let us know whether that's the normal rate or whether that's high. And added to that, there's a quarter of staff on 0 hours contract. What is the impact of having so many staff on 0 hours contract? Thank you, Chair.
Thank you. So that rate is for the independent sector within social care rather than a totality, because there's a real variance. 23.7% is actually below the national average, and we've seen a reduction over the last 4 years' data. I think it was mid to late 30s in terms of our percentage. So that is a decrease. It is higher than the NHS, so our NHS turnover rate is around the 10% mark, depending on the sector. So we are seeing an improvement, and I think that's really important. Interestingly, your second part of your question is really linked to our turnover rate. So 0 hours contract is a industry norm, and there is a national strategy around reducing some of that and what the impact is. However, we've got to recognise there is a place for 0 hours that works for our population as well. And so it's not about eradicating it, it's about using it appropriately. But we do see the causal link, and there has been a national piece of research around the impact of living wage versus real living wage versus 0 hours. And so we're trying to combine all of that in terms of how do we improve the experience of our staff.
Right, Ramsey, I think you're up next.
Thank you, Chair. Mine is to a degree a follow-on from Councillor Newton. I think we all agree with the aims and objectives set out in the paper. I think I was wanting to concentrate on adult social care. I suppose, and I would ask you just to expand on that. I am also concerned, however, about the overall figure, albeit it's 9.5%, because there's both a direct and an indirect cost, as we all appreciate, to these things. And so my first question is really, is this something that is actually recognised by government, the actual direct and indirect cost of staff turnover? Thank you.
I believe so. So one of the reasons I'm saying yes is because Skills for Care, which is the national body for the independent sector of social care particularly, have been routinely meeting with the previous government and the current government to share the research, to share the connections, and to help launch the new adult social care workforce strategy. One of those recommendations is around how does the government support improving rates of pay, contracts, and I think that's an ongoing conversation that needs to take place.
Just supplementary, I just wanted to ask about the work that you're doing with universities in terms of apprenticeships, excuse me, and graduates, and in particular what is actually being done about nursing, given the level of fees and the position that they are now in. And this again is about this trade-off between cost that we actually experience and how do we actually redress that position on a long-term basis. Thank you.
So my answer to that is it starts before universities and around how do we support much younger people feeling that this is a good entry into health and social care, but also the alternative routes. So particularly thinking about the cost of going to university and the student loans, you can enter and become a nurse through the apprenticeship route. So becoming healthcare support worker to nursing associate to nurse. So that's part of it. It's starting at the right point of your career journey. The second part is our working with universities to understand the data. So how many people start and leave nursing careers? How many people are measuring their experience in rotations and what that looks and feels like? And then how many people stay in LLR? Because that's obviously really important to us. So we are partnering, we're having those conversations, and we're having it across all of our professional groups, so nursing, allied health professionals and medics, and particularly University of Hospitals of Leicester are doing a huge amount in those connections between all the different schools, LPT as well, but particularly from a large university hospital trust.
Thank you. Thank you very much, Ramsey. Ross.
So my question is more about the geographies of where we're recruiting people from. So it's fairly well established within healthcare that rural and coastal areas struggle to recruit healthcare workers, and it's seen that there's two reasons why you'd work in a particular area. Either you graduated from there at university, or you grew up there in that area as well. So you know, I'm grateful that in the recruitment aims that you've got here is identifying a strong LLR identity and trying to appeal to younger people or new graduates. So I'm just curious if you could expand on how you're doing that.
Just for clarity, is that for the whole of our workforce or a particular professional group? Because it is different.
Well, I thought they'd be the same, to be honest with you. I mean, so I come from a dental background, and I graduated in London. And when you do your foundation year, you have to rank every single area in the country. And when you clicked on Leicestershire and Rutland, it highlighted things like the sports facilities that we have, the open spaces that we have, the culture. And I thought it was really fantastic to try and pull people towards Leicester and get them to stay here. And so my question was more about that in general. And I understand that that happens in medicine and all disciplines, but if not, you know, please do correct me.
Sorry, is that better? So I think there is something around what attracting people to Leicestershire and Rutland. I think that's a part of our role across our local authorities as well as health, and I think that's part of the, we call it the employee values proposition. So the EVP and the private sector are much better at doing this around your brand. And then the second part is, what can you expect when you come and work for health and social care? What we're not particularly good at the moment, and that's something we're working on, is the consistency. So if you walk into my ICB organisation, your EVP will be very different to when you walk into a UH Health hospital. And so actually there's something around, there's no one way, because it depends on what your profession is, how you want to work, what attracts you to that sector. But actually, what's those minimum standards you can expect from us? So we do have things like a live video around what's it like to work in an ICS. What is an ICS? What could it mean when you come and work for us? What's the value? If you are a trainee in London thinking about where am I going to spend my career, because what we do know is once you move into an area, you're less likely to leave unless something catastrophic happens. But it's attracting people in that first place. So what you need as a trainee doctor versus what you need to enter the workplace at 18 is very, very different. The other thing we do particularly well is around entry experiences, and that's generally not always around apprenticeships, but using the Prince's Trust, King's Trust as is now known, using some of the experiences around care to spend time in our sector. So I think there's a range of things that we do.
Thank you very much. Have we got any other questions? I don't think we have. Alice, thank you very much for that.
You're welcome.
So I made the point at the beginning about, you know, through adult social care, there's sort of 30,000 or potentially up to 30,000 people working in different authorities and different areas across the area. There's 25,000 NHS staff and also a few thousand primary care. I mean, it's a huge number of people supporting residents across the LRR area. I think, you know, as a result, the complexity of recruitment and retention is obviously quite bespoke, because some areas will be requiring probably a different focus to maybe others. And Ross has made a very interesting point, which I must admit I hadn't appreciated, particularly how a lot of the medical staff sort of come to be in the Leicestershire area. But it's really important from your perspective, I guess, to get that mix right. The paper goes some way to explaining some of the sort of subtleties in doing that. And likewise, thank you very much for being able to answer the questions. As we heard at the beginning, there is a fair amount of flux happening at the moment. Never a dull moment is probably the most awful statement anyone could ever make. But good luck for the next few months, trying to understand what this means, both for the ICB, but also across the whole of the area. And I'm sure this committee will no doubt be looking forward to hearing from you again in probably a year from now to find out precisely how the dust has settled. So thank you very much.
Thank you so much. Thanks, everybody.
Okay, thank you. So we are now on to our last paper of the day, which is paper 10. This is the LRR Women's Health Programme. We have a great team coming up to the table now. So once everyone's being able to sit down, and I think Melanie's lost a nameplate. I kept on looking across the sofa, thinking he's changed his name, but obviously not. Okay, that's great. Thank you very much. So, look, we have in front of us today Melanie, who's the head of women's maternity and neonatal transformation at ICB. We've got who else have we got? We've got Laura over there, who is the Leicester City Public Health consultant in women's program and women's programs champion. We've got, who else? We've got Holly, likewise from County Council here, from the public health team, specialist in women's program. And also, by the looks of it, yes, there we go. We've got Katie as well, who's from the LRR ICB Women's Program Manager. So thank you very much for joining us today. As I mentioned on two previous items, we always take the papers as read. And so thank you very much for submitting the paper that you did. And that's really, really helpful for starting the discussions. But would anyone like to actually chip in to draw in any particular points? Thank you very much. And then we'll kick off the discussions after that. Okay, thank you.
Thank you, Chair. Yes, I just want to highlight a few points, basically. I'd like everybody to note that the work we are doing locally is in direct response to a national strategy, the Women's Health Strategy, which was published in 2022, which is a 10-year ambition to improve outcomes for women and girls, looking at improving the gender health gap, reducing inequalities, and perhaps most importantly, allowing us to engage and listen to women better. This is very much a system piece of work and requires collaboration across system, organisations and programmes. But because of that, that gives it its richness to have a far-reaching impact and benefit beyond the women's programme itself to the wider national strategies that we have in place today, such as the Darcy Review, the long-term plan, elected care reforms, etc. I'd like you to note the breadth and depth of the work underway in this programme, and also to note the women's health hubs, which have only been up and running since June, which are already really starting to show how we can really improve women's health by delivering it in that locality manner. You will also note in the paper that we've responded to one of the questions, which was around screening for disabled women, and we've highlighted the range of options that are available and also the work we're doing to improve communications and make sure women are aware of what's available to them. I think I'll probably stop there, Chair, and we'll await questions.
Thank you very much for that. So, Betty, do you want to start off, and then if anyone else can raise their hands while Betty's talking?
It is a bit worrying about women and mental health, and a lot of it's hidden out there in the communities. I have my patch is very diverse. It's got a village, it's got a suburban area, but it also has got little streets basically but there's a lot of students there also living there, or a lot of older women living on their own. And I remember, I probably mentioned it before, one of them said to me they suffered from the most common disease in the world. And I says, what was that? And they said loneliness. It's never left me, and that was many years ago. But it's those hidden, and it's not just women, it's men too, basically. I don't know what more can be done, whether we can use Leicestershire Matters, but I'm sure many of them don't read the papers. What more can be done to let people know what they can do in terms of loneliness, what's out there for them, what community groups they can attend, how we can reach out and get them to get themselves more involved in the communities. In other words, how can we help them to be less lonely? Thank you, Chair.
I think that's a really good point. And I think some of the work we're doing is about, I think it's about that engagement again, because we need to, one of the key pieces of work we're doing with the Women's Health programme is reaching out to women and looking at, I think we need to know how they want to be contacted, how we can engage with them. And I think it is important to do it at local level as well, in their own communities, and how we're linking with family partnerships, but also with the kind of the work that's being done at communities. So I think that's a really important point. I don't know if any other colleague wants to come in.
Yeah, I imagine Holly will probably be able to comment from a county point of view. I just look after city in a public health context. But yes, social isolation, big issue that we're very focused on. We have a number of work streams that look at how we manage social isolation, including a couple of things we have going on in the community. We work in partnership with our libraries and community centres to put on events, things like we have a programme that's called Let's Get Together that encompasses a number of things. So if it's somebody who's city-based who was looking, I would recommend looking at the City Council web pages and the Let's Get Together. But we also engage regularly with a range of community and voluntary sector organisations who are obviously all brilliant, all have great stuff going on, and therefore, so I would probably also encourage people to look into that. But it's something that we're really aware of as an issue, and something that we need to make sure that we reach out to people rather than just waiting for them to come to us.
Some of the libraries are actually quite remote from where people live. I mean, I'll just, as an example I use is where my students live. I've got a lot of, not just women, but men living on their own who are quite lonely. But they really don't, and I don't know whether Leicestershire Matters or something could be better used to actually highlight what's out there to help them. But they're really very, very lonely, and what more can we do to help and support them? It's more or less signposting in many ways. Thank you.
Yeah, and I think that the problem of rurality and transport is something that's quite different from the challenges that we have to look after in cities. So I'll hand you over to my colleague for that one.
Thanks, Laura. Yeah, I believe a paper might have came to County Scrutiny a couple of weeks ago that covered kind of mental health and isolation. So I don't want to repeat some of the work that was within that. But obviously within a county perspective, we've got the local area coordinators. We can have linked to social prescribing. I think it's kind of touched on in the paper lately is this kind of move to neighbourhood models of care as well. So I think that's something that we will see more as we start to progress. And Mel touched on it as well through the engagement exercise that will let us really capture women's voices and hear what their challenges are around their health, and that will supplement the work that we're currently doing through the health needs assessment around that, and that the plan is to pull together the recommendations and what we've found from the health needs assessment and this future engagement and really come up with kind of robust recommendations that are based on women's voices and kind of put that into the other services that we've got as well.
Thank you very much, Bessie. Right, we've saw a flurry of hands, so I'm going to actually name some names and then hopefully we'll point at people and hopefully we'll have get on. So, Sophie, I think we saw you first. Then it was Liz. Janet, you had your hand up as well. Ray, I saw you, but before you was Mike. Hardik, you've got yours up as well, is that right? Harsha, sorry, apologies. Who else? Well done. And Brenda. Anyone else? And then Liz. Liz will bring it all together with the best question of. Oh, sorry, Karen. Apologies.
Right.
I've got this long list of names that I'm desperately trying to actually remember them all. God, dear.
I can't remember the order.
I don't even know who I am anyway. So
Yeah.
there we go. Right, let's go with
Sorry, can I just quickly answer that point because that was raised just a little while ago because it's something really pertinent to me. In my ward, I have two elderly ladies, 189, 192. They used to use the dial-a-ride service in the city where they used to go to Tesco's once a week, do their shopping, have a cup of coffee and come back, meet some of their friends and come back. That service has now ceased because of funding issues and I'm raising it in Leicester City Council. And I actually took those ladies last week to Tesco's, did their shopping and everything else. That's the only trip they make out in 2 weeks. That's the only visit they leave when the point they leave their house. And it's so good for them to be able to walk around Tesco's, do their shopping, pick out new items, try new foods, meet their friends and socialise. So when we are doing budgets for transport services, we need to look as councillors long and hard what we're doing and how we're doing it, because it has a serious impact on the most vulnerable, most fragile people in society. And that was all I wanted to say.
I was going to say, good question for City Council on the Transport Committee rather than Joint Health and whatever. But if you want to ask, do you want to ask a direct question?
First of all, can I just say how much I was delighted to hear about some of the services that women's services are providing. I happened to be doing an interview with Flo and Dalvey yesterday on the very subject, and it was so good to see the direct referrals for people who are pregnant. They don't have to go to their GP, and the reflections number, so that people who have had issues in the past being able to call up and somebody look into that. And that was a fantastic service. So, you know, real credit to the service. My questions I've got is perinatal services. This was a service that was provided in Leicester before, up until about probably 5 or 6 years ago. Is there any chance of bringing that service back to Leicester? Because lots of ladies who don't necessarily speak English as their first language haven't got the family support. Nottingham or Derby is too far for them to travel and for their family members to travel and access as well. And the second part of my question is there a freeze on band 5 midwives, the people who are newly coming into the service? Because that was raised with me a few weeks ago as well.
I'll try and answer those for you. In terms of perinatal, do you mean perinatal mental health inpatient? That moved a number of years ago, and as far as I'm aware, there is no plans to change that. What we are doing and what we have done is implemented a expanded community perinatal service, because our aim is we try and keep women at home with their babies so that admission is as short as possible and that their return can be quicker. So unfortunately, I don't think there are any plans. But what we do need to do is continue to build on that service and make sure if they do have to have a stay in inpatient, it's short and we get them back as soon as possible. In terms of your other one about the band 5s, I'll have to take that back to UHL, but my understanding there isn't, quite the opposite. There's a recruitment drive in maternity.
Okay, thank you very much. Now, having gone through that long list, I've completely forgotten who was next. Was it Liz? It was Liz, wasn't it?
Hi, my question is about wheelchair-bound ladies. It was me who raised this question about, so I've been having the dialogue with constituents about it. It was actually raised by a lady who was at a GP practice in Market Harborough. That's where it came from. So I welcome the improved comms and the links and all that type of thing, but I still have a concern. I have a concern about, I don't know if we know how many this affects, how many ladies there are that are wheelchair bound. I don't know if we know how many GP practices have hoists. I would have thought there would have been an element of choice, and then potentially if you are a wheelchair bound lady, to direct you to a practice that has a hoist, I think would be beneficial. My concern comes as well from some previous experience I had with mental health, where we were directing people who were going for referrals for mental health. They're having particular issues to get that referral, and then they never went back again when it was resolved. And that's what worries me about this, is that we may have ladies who get told to ring the hospital or do whatever, and then they don't do it and they're lost. And the lady I spoke to, who's a patient at Market Harbour, has never had a smear
And she was the one who raised it with me and said, look, I want a smear, so I'm not saying I don't want one, but I've never had one. And so we don't seem to have any numbers on it. We don't seem to have an idea of the scale. Perhaps it is only this one lady. We don't seem to have any idea. So that's what I would be really keen to see.
Okay, lovely, thank you. I don't know if Katie, you're able to pick up any of that for us.
Yes, so this work actually flows through the cancer partnership within the ICB, not specifically within my programme. However, we do have a section within our women's programme plan to cover cervical smears, and also through the Women's Health Hubs to ensure that we're looking at that uptake as well. I couldn't tell you the data on that or the breadth of that at this time, but what I am happy to do is take that back to the Cancer Partnership on behalf, and then send back some more information on that. But I do agree, I think we need to look at it from a more systematic point of view. Thank you.
What you may have said to you is that it's not easy to find out the data from the GP practice. That's actually not true. So I used to work in implementing IT systems in general practice. So the ICB can send in people, the transformation managers, and do searches on the data as long as it's anonymised and everything. Ask the practice to anonymise. So I'm just sort of forewarning you, I suppose, just in case you get that pushback.
Thank you very much. So I think the next on the list was it Michael Janet? Who was next? Go on then. Okay.
I'll say thank you, Chair, and thank you, Mr. Charlesworth. Yeah, I'm just sort of thinking, I enjoyed reading your paper, and I think Rutland actually has been piloting the Women's Hub. However, I live in Rutland, and I have never heard any mention of it whatsoever. Your paper doesn't say how people can access it. So I don't know, basically. I asked our manager if she knew, and she wasn't sure, but she thought it was through the GP. So the whole engagement process is not working in Rutland. My second sort of point is that although what you're doing is really brilliant for women, but it's very much focused at younger women for contraception, pregnancy, menopause. What happens to the people post-menopause? There doesn't seem to be anything that I have to declare an interest for that.
I literally don't want to know.
I'm really only 21. But I feel there's a gap there because you're then overlooking things like osteoporosis and various other intimate things.
I'll pick up your last point and then I'll hand over to Katie about the hubs. I think you're right. And remember I said at the outset, it's a 10-year programme. So we focus on some key elements that we were asked to do through the national strategy that were identified as priorities for the first part of the programme. But you're right, it's bigger than that, much bigger than that. And the actual programme is about a life course. And I think that's what's really good about it. It's not just women are more than their reproductive organs at the end of the day. And this is why this programme's so important. It's not about one end or the other. It's not about the women in the middle. It's about the younger group as well. You know, young girls who are just starting with their health issues as teenagers, and you're right, and the more mature ladies like ourselves that are getting to the other side of it, and that is the beauty about this programme. But we have focused on those elements because those are what the national programme required us to do. But be assured, going forward, it is about the full life course approach we're going to be taking.
Could I just ask whether you're going to actually start to do breast screening, regular mammograms for the over 70s, calling them in for them, because this is something that is really wanted. I'm always picking it up, and it's just not happening.
That I can't answer. I can take it back and ask the question for you though. But Laura, did you want to come in?
Yeah, I was just going to come in on that point about the life course approach, and yes, a lot of the sort of services that are currently offered in the women's hubs are based around those the core services that we were given a list of, so things like contraception, menopause, but there is also some community gynae, which will be looking after ladies who have prolapses, etc. And the health needs assessment that we're currently doing, one of the 14 priority areas within that are things like issues that affect women in later life, so post-reproductive life, things like osteoporosis, frailty, falls risk. There's a little bit about cognitive impairment as well. Obviously, because those are also the subject of whole other areas of work within the system, we can't go into loads of detail, but yes, certainly that element is very much in there as part of the work that we're including.
I just wanted to come on your point around the engagement on the hubs, from the hubs out to the public. I just want to say, number one, I apologise for that you've not heard anything, and there isn't that level of information in terms on how you're able to access that. For women in Rutland, yes, they go through their GP practices and they're then sent through to the women's health hubs, and that's the same for the one in the city and also the one in North West Leicestershire as well. All three women's health hubs were, they put together their own engagement comms package for the population that they're serving, and we'd also sent out a ICB brief to the system on where the women's health hubs were and how they could, how women in the population could access them. What I would say is that we've moved at pace with this pilot in terms of the time frame, and I think it would actually serve as well if we could take a look at it as part of the end of year review, which is upcoming in the next couple of months, to relook at how did we engage and then how can we re-engage through our not only our engagement programme plan, but also through the second year of the Women's Health Hub pilots too.
I'm going to limit you to 2 in future, Janet. Oh dear.
Do you have to go through a GP? Is it you have to go through a GP, or can it be changed so that women can approach the health hub directly? I'm bearing in mind the difficulty in actually seeing a GP or getting access to a GP.
Yes, absolutely. So the at the moment is only through GPs, and the reason for that is because they're pilots. We've got a limited amount of women who are able to see the women's health hubs at the moment. However, in year 2, we are looking to expand that through ICB primary care colleagues, and also the sustainability of the ones that are currently in place as well. We would like to open out to more of a direct referral route from the women themselves, maybe through the GP websites, but that's something that we still need to look at in year 2. As I say, we are still only in year 1, and year 1 is due to end imminently, so year 2 plans will be in place.
Thank you very much. Harsha, do you want to go next, and then we'll bring in Mike afterwards?
Yeah, thank you. I just wanted to say I really welcome all of this work around women's health, because there are so many health inequalities, especially for across the city and the county. And we are actually working with the team as part of the engagement. So this paper's coming to our board tomorrow evening, which we're looking to hopefully approve. We don't exactly yet know what the work will involve, but it's likely that we're going to be working with you to engage with the population, because we've got that link into specific populations, so that would be really helpful.
Excellent. Look forward to seeing that report in the future, so thank you very much for that. Okay, Mike, do you want to come next?
Thank you, Chair. Yeah, it's the first bullet point on page 28 about deaths during pregnancy. I just wonder if you could have tapped down a bit, and deaths during pregnancy and deaths during childbirth, because I mean, pardon my ignorance on this, I thought the chance of dying during childbirth was fairly minimal. So it would be nice to know exactly the figures around that, and why black women are 4 times more likely to die. I'd like to know. And my second question is going to be, I've just had a AAA, abdominal aortic aneurysm screening, because I'm at that age. I was okay, but it just describes the process. Why, and I know this is embedded, why is a smear test called a smear test? Did a man come up with that phrase? I mean, something better surely can be used to describe that process.
Do you want me to take both of them? So yeah, I should probably say that my other kind of hat in this ring is that I'm an obstetrician and gynecologist part-time. So yes, I've asked those questions. So it's just called a smear test. It used to be called, so you hear Americans call it pap smear. It was named after Mr. Papanicolaou, who invented the thing, and it was literally where you took a scraping and then smeared the cells on a slide to look at it. Technically now we don't call it that, we call it cervical screening or cervical cytology screening, but the name has persisted. But yeah, it's not really what we call it anymore. In fact, most places now don't even do the cells in the first instance. They do primary HPV screening, actually. So they just look for the presence of a virus rather than doing the old smear test. But yes, good question. It probably needs a bit of a PR upgrade, I think. Your first question is a really good question. So maternal death is an official definition. It refers to anybody who dies in the period of pregnancy or in the 6 weeks immediately following. And we split them up into direct or indirect maternal death. So direct maternal deaths are anything that result from the pregnancy itself. Indirect maternal deaths are things that are where you die as a result of a pre-existing health condition, but that might be exacerbated by your pregnancy. So something like cardiac disease, lung disease, something like that. If you die during pregnancy as a result of an accident or incidental cause, then that doesn't get included in that basket of causes. We do also talk about late maternal death, so that's up to the first year following childbirth. And sadly, most of the cases in that definition are women who take their own lives as a result of postnatal depression. In terms of local data, thankfully, this is still a very rare outcome, and therefore we don't tend to report it at individual case levels just because of it being so few numbers that people might risk recognizing someone they know, a loved one, whatever, in that sort of data. But there is a national organisation called Embrace based at Oxford, and they publish a report, I think they do a little kind of report every year, but they do a big triennial report. So they group the data into 3 yearly, and you can have a look on their website, and they publish a summary, and it talks about all of those things that you're asking. But the other thing that they do are highlight those important things that they see in the data. And one of those was, of course, the fact that Black women are 4 times more likely to die during pregnancy or childbirth than white women. We also saw that discrepancy in people from Asian backgrounds. It was 2 to 3 times more likely. Equally, people from more deprived backgrounds. So we see that inequality play out. And why is a really good question. And if I had a complete answer to it, then that would be great. It's likely a result of a whole load of different intersecting causes, and there's a lot of work going on both nationally and locally to pick this apart and look at it. Our colleagues at UHL who work on equity, they've been looking in detail at this, both at their data. They've been talking to people in the community and picking it, but it's something that we're going to have to tackle across multiple things. And certainly there's a lot of work that's already been going on, but I think if I were to try and elucidate all the causes now, we'd be here for several days. But it's something that's very much at the forefront of our mind.
Thank you. It's nice to know that you're trying to understand the why.
Yeah.
Which is the thing.
Yeah,
Thank you.
Because we'll never solve it until we understand why.
Thank you very much, Mike. I think Ray is next, and then we've got Brenda, and then Karen. Is that right? Have I missed anyone else? No. Okay, Ray.
Thank you, Chair. I just want to return briefly to the question of isolation. I work and represent a very rural area at Rutland, and isolation is a real problem. It seems to me if you live in a rural environment, if you're also not very au fait with technology, and you're female and over 70, you've got 3 strikes really heavily against you. It's probably not good if you're a man fitting into them, but it's even worse, I think, if you're a woman. And this is something we face on a daily basis in Rutland. And I'm going to do a shout out here, Chair, unashamedly. I'm going to shout out for a wonderful organisation called Voluntary Action Rutland, which provides cars driven by volunteers. It's how I came into this sign, and whose fees are much less than taxes, and who do a marvellous job in moving these people around for all sorts of appointments, many of them here in hospitals in Leicester. And it seems to me, and this is my question, since the state is clearly retreating, the voluntary sector, particularly in Rutland, is essential. We rely on it. What plans do you have to increase your cooperation and help and knowledge of the voluntary sector?
Question. So I'm coming at this from a public health point of view, so we do try and engage with the voluntary and community sector as much as possible. A lot of the work will come back out through the health needs assessment and the engagement. So once we actually understand what a lot of the needs are, then we can look to see what needs to be put in place. And then a lot of this also goes back to that neighbourhood models of care. So as the ICB starts to transition their models of care, hopefully care will be delivered more within localities rather than the bigger hub sites. But again, obviously with all the announcements that we've heard last week, I think a lot of it is a kind of watch this space to see what happens as we move forward.
There are a number of volunteer bureaus throughout the county, and quite often many of them have drivers, volunteer drivers who take people, they're well insured as well, take people in and out of hospitals and all. So it's worth checking with your local volunteer bureau whether or not they offer that service. I know where I come from, they do. Thank you.
Thank you very much. I think this comes back to the point about signposting at the beginning, which is critical, just understanding where the help can be. Sorry, Casey, do you want to?
Yes, thank you, Chair. So that links quite nicely with the work that we're doing with the Women's System Partnership. So not only does the Women's System Partnership, which is a brand new partnership, link into ICB areas, it also goes out to public health as well. And last year I attended a VCSE event, and it was enlightening to understand how many VCSE organisations there actually are across LLR. Who knew? So what I have been doing with our ICB comms and engagement team in the background is looking at bringing the Women's System Partnership to the VCSE organisations so that we can understand what is actually available from a strategic point of view, and also to link in with our health news assessments and engagement, but also for them to understand what we do as well. We also have really good links with our primary care transformation colleagues, and others as well. So hopefully the Women's System Partnership can be a good vehicle to begin them discussions. At the moment, the Women's System Partnership has flurries of VCSE organisations which attend. As you can imagine, keeping it at quite a strategic level can be quite difficult. So that's why we want to go to them and just understand a little bit more. So hopefully I can assure you that the work is in place, and we're going in the summer. So hopefully we can bring something back.
I'm really pleased to hear that. I think my last count was 178 voluntary organisations in Rutland alone, and still counting. And also, just a shout out for the older ones, of which I'm one of the representatives. We're not always a burden. We do actually have quite a lot of knowledge and expertise, and we have time. So we should be looked on more positively as a resource rather than a burden. We'll do our bit to avoid being a burden as long as possible, I do assure you. So perhaps a mindset change.
I think any of us consider you a burden, I should just say. We love our voluntary sector colleagues.
Thank you very much. It's a great reminder that the voluntary sector, I think, is the glue that holds society together. It is extraordinary, absolutely extraordinary. So I think we're on to Brenda now. Yeah. And then we're finally on to Karen.
Well, I was going to, and I can remember doing it either last year or the last time we met, but I think it was last year when the figures were out, for premature deaths under the age of 1. And there seems to be, looking at the Leicester map, there seems to be no rhyme or reason where the statistics were higher than others, but that has been answered. But whilst I was reading through that, I also came across the health inequalities and pain bias. It was something that I'd probably not even thought of before.
But as with deaths and more black women die than white women, etc., and so on, that's data and it can be easily measured. But this is pain bias where a health professional overlooks or ignores the level of pain for black women. And I wondered, what do you do? Because the medical profession is very diverse. And it's not all middle-aged white men, so it is a mixture of ethnicities. But even in the mixture, it's saying that health professionals overlook and ignores the level of pain. What are we doing to address that, or what do you do? Is it a cultural thing, or? Thank you.
Thank you. Yeah, great question. And that's, that sort of idea of pain bias and the old-fashioned and incorrect but persistent idea that black women either don't have a higher pain threshold, don't need as much pain relief, etc. And that's one of the many things that you come across when you start unpicking this issue about why black women, for example, have different experiences. And one of the difficulties of making short generalizations, of course, black women are not one homogenous group. They're all different, who have different experiences. And I think those women's experiences are the key to solving this problem. One of the criticisms of the Embrace reports that I referred to earlier is that they do just present data, and they therefore tend to kind of skirt around this issue of intersectionality, but experience and calling it what it probably is, which is that systemic racism, the way that the system is set up not to look after everyone equally through no one individual white person's fault. And it's something that I think everyone is becoming more and more aware of all the time. Our colleagues in UHL, so Councillor Hack earlier talked about Flo and Dalvis, so that's our midwifery matron and our public health inequalities midwife. They've been doing some really brilliant work on creating a training package around something called cultural humility. So we used to refer to it as cultural competence, but now that's been expanded into sort of a few different dimensions. But it's about helping healthcare professionals to address any subconscious or unconscious biases that they might have, anything that they might think that turns out to be correct, and also delivering care to patients in a way that kind of understands and appreciates those differences in the way that we view things. We might, we view health, we view life, we view all of those things. So it's not something that's going to happen overnight, but I think it's something that is happening, and it's very important that it does happen. And I think the other element of it is making sure that we continue to hear patient voices in this. So as part of that partnership with the UHL that's looking at maternity equity, one of the things we are doing is commissioning a piece of research to look at the experiences of women, well, not just in the city, actually across LLR, from various communities, and to talk to them about why and how they choose to seek help, or otherwise in pregnancy. Why is it perhaps that they might delay coming to see us till 20 weeks or whatever, or and what are those things? Because we know that that's one of the factors that leads to these outcomes, and we don't know why that is currently, what's putting people off. Do they not know? Do they not understand? So until we really understand a lot more about that, that's where we're going to try and really address this stuff. But thank you for raising the question, because it's a really important issue, and it's something that still people don't always feel that they want to talk about or ask about. So thank you.
Thank you very much. That was, a great question, but really informative answer as well. So thank you very much to Brenda and Laura on that. Karen, do you want to come in at the end?
It's good to know that women's health is on the ICB's priority and in the 5-year operational plan, which you've been regionally recognised for. Is that right? I just wanted to go back to the isolation bit, and I'm sure, Laura, you'll know about the mental health cafes that have popped up around Leicester, but I'm sure they are now heading towards the county, and they've been really successful in Leicester. But we've got 3 women's health hubs in Leicester. Are we not allowed to know where they are?
Yes, it's not a secret. I can absolutely tell you where they are.
But I'm sure I read in the paper that you could self-refer as well via the NH app, or it might be further down the line.
Yeah, sorry, that's further down the line, yes.
Yeah. But I think it's really important, because I do think that women are proactive about not only their own health, but their husbands' or partners' health as well, that they get that chance to do that self-referral. I know when you go for a GP appointment, I felt quite rushed. And I've had a few cases this week where women have wanted more help with menstruation pain, that sort of thing, and they've not been referred yet. They've been to their GP. So I think, as well as promoting it in the medical profession, we need to promote it outwardly as well, so that people can be a bit more proactive and book themselves in, which frees up telephones, GP's time, and they can refer themselves straight away.
Yeah, I think the self-referral model is always a good one for helping. Yeah, all of those things you've alluded to, helping people take control of their health. And there are other kind of areas of the women's health space where that is happening. So, for example, our sexual health services in City, you can self-refer to, where they do provide contraceptive services. Our termination services now at UHL, as well as BPAS, that's termination pregnancy service, you can now also self-refer, because we're recognising that is the model that works well. But as Katie's alluded to, unfortunately, it takes time in terms of making sure that systems are set up for it.
Yes, thank you. Also in the pack of papers I had, there's hopefully should have been a slide deck attached to that, which does have the information on where the health hubs are. There is, as I said, they are on primary care network footprints initially for 2 years, just so that we're able to pilot that proof of concept and really look at what works for women. The 3 models are different in each area, so that they've been tailored towards that population in which they're serving. All 3 women's health hubs have 20-minute minimum appointments. They have been known to average out, well, not average out, up to 40 minutes for some of them. For the one in City, they have a no turn away policy for women. So if you walk in and you're happy to wait, you can be seen. But obviously these policies won't work everywhere, so we're going to look at how we can do a joint MDT approach with the other 3 hubs initially. We can collate the lessons that we've learnt, and we can look at disseminating that out to wider primary care. All 3 of our hubs also, I know they do work to the National Core Service Specification, which was handed down nationally. But what they also do is they outreach into community as well through food banks, libraries, gyms, etc. And mental health cafes is absolutely one of them that they reach out into as well. So I think mental health will automatically be encompassed within the women's health hubs. If you walk into the women's health hub for, say, for example, your cervical smear, and you want to talk about your mental health and need onward referral or for anything else, they are one-stop shops. They should be, that's what they're there for. So hopefully if you take a look at the pack, if you need any more information on that, more than happy to provide it.
Thank you also for all the members that asked questions. And thank you also for the 4 of you for the answers that you gave. I mean, really interesting paper, very informative. And I think sort of the breadth of questions that you got, I think demonstrated the sort of wide, all the different ways that people were coming into the paper to access the information and to try and actually sort of find out a little bit more. So thank you very much for putting it together. Thank you very much for coming here today. So Laura, Katie, Melanie and Holly, thank you very much for everything that you've done this afternoon. So with that, we have concluded the meeting. We're on to item 11, which is any other items the chairman's decided to take as urgent. There are no other items. So I'm going to formally close the meeting. I'm also going to thank all of you. This is my last, as I was mentioned to Karen earlier on, this is my last, and I mentioned at the beginning, this is my last council meeting that I will be attending. I've had 14 years, my God, 14 years as a councillor. Oh, well, there you go. But that was a very good lead into what I was going to say. I appreciate, because obviously there are elections for the county council. There are many people around this table who are not standing again, who have served their community for a long period of time, as Betty has just demonstrated. And thank you to all of you for what you've done. For those who are restanding, I'm looking at you in particular. Over there, Brenda, and also I think Nick and various other people as well. And for all those who are not going to go through elections on the 1st of May, well done. You don't have to do that for a bit. But whenever this committee is reconstituted under the able support of the City Council, hopefully it will carry on doing some good work. I'd like to pay thanks particularly to Euron, who's clerked this meeting, who has been extraordinarily good at keeping me in line and prodding me every now and again, particularly when I make errors on people's names and particularly my own. So thank you very much, Ewan. You are an absolute star, and I appreciate everything that you've done for us over the last couple of years, but also much longer than that, obviously, on the County Council side as well.
That's Mike as well in the background.
Indeed.
For his quiet hand and leading us. Good luck.
And Bessie, I'll give you the £20 later for actually saying those kind of words. Okay, all of you, goodbye and good riddance. Goodbye.